Welcome, everybody. Actually, we're one of the first conferences, and this is Epilepsy Awareness Month in November, and I think we have a great diversity of speakers from throughout the region. Valley Medical Center from Dr. Vossler, Swedish, Dr. Ryder. We have a representative from Seattle Children's who will be talking, a social worker, talk about transition. And we also have a researcher at Seattle Children's Research Institute who's going to be talking. So I think this will be a great presentation. And as Kevin mentioned, he's really worked hard to really get this conference up and running. And we've always taken a lot of extra effort to respond to your questions and respond to previous surveys that we've done in terms of the topics that are that people want to hear. And I think hopefully this will be something that you all will enjoy. And as Kevin mentioned, we often put these online so that people who can't attend will be able to see these afterward as well. So I just want to thank Kevin and all the investigator people for putting this together. And we're going to have volunteers actually present the backgrounds of our speakers. And the first will be Alex, who will be presenting our first speaker.
Yeah, so good morning, everybody. My name is Alex. I'm a volunteer with the Epilepsy Foundation, and I'm also a research associate at the Allen Institute for Brain Science. Our first presenter will be Dr. David Vossler. Dr. Vossler is a clinical professor of neurology at the University of Washington School of Medicine in Seattle, Washington. He is the medical director of the Neuroscience Institute at UW Medicine Valley Medical Center. Prior to joining Valley Medical Center, Dr. Vossler was the director of Epilepsy Medical and Research Services, director of the Clinical Neurophysiology Laboratories, and director of the Epilepsy Center at Swedish Medical Center in Seattle. Dr. Vossler earned a medical degree at the Jefferson Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania, where he also completed an internal medicine internship. He served as the chief neurology resident in the final year of his residency at the Boston University School of Medicine in Boston, Massachusetts. Dr. Vossler continued his training with an EEG and clinical neurophysiology fellowship at the University of Washington School of Medicine. Dr. Vossler has been a principal or co-investigator on 60 clinical research studies. He has authored or co-authored 7 book chapters, 48 research abstracts, and 53 peer-reviewed journal articles. Dr. Vossler has served on the editorial board of the Epilepsy Research Journal and is an ad hoc researcher for several epilepsy and neurology-focused journals. He is a fellow of the American Academy of Neurology. He is vice chair of the Treatments Committee and chairs the Refractory Status Epilepticus Task Force for the American Epilepsy Society. Dr. Vossler is vice president of the Washington State Neurological Society and is also a member of the American Clinical Neurophysiology Society and the National Association of Epilepsy Centers. He is past president of the Western Clinical Neurophysiology Society. And so please join me in welcoming Dr. Vossler.
Well, thank you all for joining us. I'm delighted to be here. I just want to start out by saying, actually, Kevin, this is our 25th annual conference. I know that some of you are newer to Epilepsy Foundation Washington, but when we started these programs back in 1993, we did them annually. First at Highline Community College, and then for many years when I was at Swedish, as Kenneth mentioned, we did it at Seattle Central Community College. And so I want to just put a plug in there for the many of us have been doing this for many, many years, and we're really delighted. I remember the first year that we did it back in 1993, we completely filled the auditorium at Highline. Myself and Peggy Friel, who was my social worker at the time, worked very hard, and we had over 200 people, and I'm told we have 200 attendees signed up today. Not everybody may not be here, but we're delighted that those of you that are here are here. And so my talk is, I've been asked to talk about cannabis. And it's a talk I've given a few times, starting in 2014 and then 2016 and 2018. And the landscape has changed in terms of our true understanding of cannabis and what it can do and what it can't do. And I want to say at the outset that I know that there are probably some of you that are very devoted to this substance, and you have very passionate views, but I'm going to ask you to tone down your passion and please listen to not the hype, but the real truth about what we do know about the drug. And we don't know everything yet. More studies are ongoing, but I know that, again, some of you are going to be a little bit passionate about it. I have no vested interest in this particular compound. I have no relevant disclosures. I don't speak or do any research for Greenwich Pharmaceuticals, which is the only company that has a patented approved compound. So I'm going to just give it to you like they do at the World Series. Pretend I'm a World Series umpire. Okay, I'm the home plate umpire. I just have to call them the way I see them. So that's what I'm going to do. So before I do that, I think it's important for all of you to understand, because patients are often really have trouble with the terminology and understanding epilepsy and seizures and what's what. We'll go through the seizure types quickly. We'll just introduce the fact that there are 40 kinds of epilepsy. And this product that Greenwich has for CBD is only approved for 2 of those 20 types, which are very rare types. So for the other 38 types, which are the most common types, it's not approved for you. And now I want to point out that there are 29 anti-epileptic drugs, and CBD is only one of them. Okay, there's 28 other ones, so let's not get our sights like totally focused on CBD as a total panacea. It's going to fix everything. I know that's what your cousin in Skokie, Illinois sends you on Facebook. Have you tried CBD? Well, just kind of, again, tone down the hype and let's listen to reality. We'll briefly talk about non-medication therapies, and my colleague, Dr. Gwynn, is going to talk about surgery, so I won't obviously be doing that. Well, then we'll focus really the heart of the talk on what we came here to address, which is cannabis. So what are we treating? Okay, I really detest the term seizure disorder. I hear that all the time from primary care physicians, hospital doctors, even neurologists, because, yeah, seizures are the primary thing that occur in epilepsy, but they're just a sign or symptom of the problem. The problem, the condition, is epilepsy. So because the problem is seizure disorder underestimates the other impacts that having seizures have on you or the people you love. Seizures cause lots of other things: thinking problems, memory problems, socialization problems, job problems, driving problems, depression, anxiety, et cetera, et cetera. I see some nodding heads. So saying, oh, you have a seizure disorder, that's okay if you want to tell an employer that, because I think that may be, to some people, more palatable than the term epilepsy. There are old connotations that are incorrect from hundreds of years ago, that somehow people with epilepsy have mental illness or they have developmental intellectual disabilities, and that's just not true. You can't equate the two. So some people don't like the term epilepsy. If you guys want to say it about yourself or your loved one, okay, you can call it a seizure disorder, but I don't want the doctors to do that, because I want them to think about epilepsy as a holistic condition that we have to be treating all aspects of. Okay, now many of you were aware of the old 1981 classification of seizures. And the terms there, if you had localized onset seizures, was that they were partial onset. That meant it came from part of the brain. And if they were simple partial, that meant that awareness was retained during the seizure. You could feel it, maybe it's just focal jerking of a part of your face, but you can talk through it, or it's just a sensation, or maybe it's a deja vu or something. But if it doesn't affect your awareness, we used to call those simple partial seizures. Now, this new terminology, which was published a year and a half ago, so I would encourage you to all learn the new terminology. And all you have to do is learn what you or your loved one has. You don't have to remember the whole thing. But the most common type is it begins in a spot, so it's focal. If awareness is retained, it's a focal aware seizure. If it begins in a spot in your brain, which, by the way, you're not going to know, your doctor will tell you it begins in a spot. And if you have impaired awareness, then you have a focal impaired awareness seizure, or to shortcut it, you could just say a focal unaware seizure. And then doctors can further classify it by what else happens during the seizures. Sometimes these focal seizures spread to the whole brain, like a campfire can eventually cause a forest fire. And when that happens, then we say it's a focal to bilateral tonic-clonic seizure. So band are the terms simple partial, complex partial, and band is the term secondarily generalized. These are the terms we'll be using now, so try to make that transition. I will say that a lot of your general neurologists probably don't even know this yet, and I'm trying to spread the word. We had a program, Dr. Gwynn and I did a program 2 weeks ago for the Washington State Neurology Society. We're, like Johnny Appleseed, we're trying to spread the word. Okay, so we're trying to get that information out there. You can have generalized onset seizures like my daughters used to when they were little. They had myoclonic seizures, fortunately nothing else. They never wound up in the children's ER for that. They wound up there here for asthma, but thankfully I never had tonic-clonic seizures. This didn't change much, and so don't worry about that. But I just wanted to bring this to your attention. This is a little more expanded things, and Dr. Gwynn and Dr. Novotny and others in the room and I are used to this, and again, we'll be trying to stress this with our patients. Again, focal seizures begin in a part of the brain. They can begin in the motor cortex, the movement area, so you can have jerking movements. If it begins here in the blue sensation area, you'll have sensations. If it begins in the back of the brain, you have vision changes. Most common localized epilepsy, however, begins in the temporal lobe. I remember one of my mentors, George Ogeman, and his wife, Linda Ogeman. I don't know if any of you were patients of the Ogemans. They both have retired now, but they were here at University of Washington when I came here 31 years ago. And George taught me, if anybody asks you what lobe of the brain do seizures mostly come from, always answer temporal lobe, and that's 80% of the time you'll be right. And that's true. So that's focal. Generalized seizures, here's one of the terms that describes generalized seizures that have a 3 per second spike in wave discharge. It's everywhere, all over the whole brain, simultaneously, all at once. And this is, it's a picture, so you can't do it justice, so you don't have a video. But basically, it's just a pause, a stop and stare, and then recovery without any problems following that. And of course, this is a tonic-clonic seizure. The Spanish have a term, convulsion. I like that term, convulsion. The French have a terrible term. It's called grand mal. That just means big bad, so it's not very helpful. Grand maladie means big illness, depending on which way you want to translate it. So try to use the term tonic-clonic, and that's where a person stiffens all over. They're completely unconscious. They often extend their arms and legs very rigidly. Sometimes they'll be a little flexion, and then toward the end, there's the vicious kind of clonic jerking. So tonic, increased tone. Clonic means claw-like, and toward the end, then they, once it's over, they will actually they don't get blue at the beginning, they get blue at the end because of the oxygen is not flowing they can't breathe during the seizure. Keep in mind, most of these seizures last a minute. So, that amount of not breathing is not deadly, but if they last longer than that, it can be dangerous. First aid, by the way, is turn them on their side as soon as it's over, so that any saliva drools out onto the floor or pillow or whatever. Open the airway by tipping their head back and never put anything in their mouth. So again, epilepsy is what we're dealing with, not really seizure disorders because of all the associated problems that occur as a result of having seizures. What makes an epilepsy syndrome? Well, there's 40 epilepsy types. We base it on knowing what kind of seizures they have, knowing what the causes are for the condition, whether or not genetics plays a role. You'll hear some discussion about a very rare epilepsy syndrome called Dravet syndrome. I have one patient with that, so it is pretty rare in general practice. Memory problems, thinking problems, depression, anxiety, fertility difficulties, sometimes related to the drugs. I didn't put drug side effects here. I should do. I'm going to add that here after my talk. I left that off by accident. Job concerns, socialization issues. Pain is more commonly reported in people with epilepsy. Attention deficit disorder. The list goes on. So you see, it's not just seizures. So we now have a classification of all the epilepsy syndromes too, and this is just, I'm going to just show you this one pretty picture and don't worry about it. This is taken from our international journal called Epilepsia, and basically, again, we know of over 40 types of epilepsy. And don't remember this slide, you won't anyway, but this is the website you want to know about, epilepsydiagnosis.org. You really should ask your neurologist, what epilepsy syndrome do I have? Not just what kind of seizures do I have, but what epilepsy syndrome do I have? And if they don't know, you may want to come and see someone like myself or Dr. Gwynn at our epilepsy centers. We're what are called epileptologists. You go to dentists, there are general dentists out there, and then there's people who do just gum disease. They're called periodontists. There's people who just straighten teeth. They're called orthodontists, et cetera. There are neurologists, and then there are subspecialists like us called epileptologists. So if you're not getting questions answered, if you don't understand things, seek a higher level of subspecialty expertise. How do you select anti-epileptic drugs? Again, you want to classify the seizure type. I need to understand what it is you have if I'm going to pick drugs correctly. Ideally, we'd like to know the epilepsy syndrome. Do you have temporal lobe epilepsy? Do you have Dravet syndrome? Do you have Lennox-Gastaut syndrome? Do you have frontal lobe epilepsy? Like my daughters, do you have childhood myoclonic epilepsy? And the EEG is one way, and these MRIs, imaging tests, are another. And once we get all the data together, we can figure out a treatment plan for you that's not guaranteed to work, but at least it's based on rational data and real science and not just guesswork. Oh, well, I guess we'll try the 28th drug here and see if that one works for you. We'd like to be more scientific than that, and we'd like to get to the day, if it ever happens, where we can do a blood test, type your genome, and say, well, you have this gene risk for epilepsy, and I know in my computer that when you have this drug's likely to work. We want to get to that day. They're doing that in cancer. They're doing it in breast cancer, especially in oncology. We need that in neurology. It's not quite here today, a little bit for some syndromes like Dravet syndrome, but it's not there for everything. Our goals are simple, but not so easy to achieve sometimes. Seizure freedom, improved quality of life, no adverse effects, simplicity of the treatment regimen, and no drug interactions. So those are easy goals to state. So I'm not going to talk about surgeries. That's for Dr. Gwynn to discuss. I wanted to bring out the landscape of anti-epileptic drugs. So this is drug development starting with the year the Titanic sank. That was when phenobarbital was synthesized in Germany. I don't actually know when it came into common practice. It was synthesized by a guy named Hauptmann in Germany in 1912. Phenytoin was developed at my home training program where I trained in Boston City Hospital. It was developed by actually a neurosurgeon and a neurologist there, Merritt and Putnam. And phenytoin was developed in 38, although it wasn't marketed until 53 in the United States. So, and you can see that during my training here, which was over in here when I was in med school, these are new drugs. Well, these two, actually. This one had just come out before I went to med school. I take that back. It was college, so med school was here. I was in the phase where we had nothing for 50, I'm not kidding, nothing new for 15 years. And when I came to Seattle, we were stuck with these drugs. And then you can see what's happened. These are what we call the second generation drugs, only because of the years they were developed or approved. This is the approval years. And then the third generation ones, we just kind of came up with these terms, not because the second generation's better than the first or the third's better than the second, but rather because of the timing of these things. And so this year alone, we've had these 3 drugs approved here. And I won't name names because that's not really the point of the talk. But again, remember, cannabidiol is no better than any of the rest, and it's just one of 28. We lost as ezogabine, that one's gone, so it shrunk the number by 1. And if you're really interested, these are the first generation drugs. Bromides are no longer available. Technically, that was the first anti-epileptic drug ever. And then we've introduced the second generation ones and some devices here, vagus nerve stimulator, and then down here, the third generation drugs, the responsive neurostimulator. And this year, too, the deep brain stimulator is now FDA approved, plus 3 new drugs. So pretty exciting. I mean, I've been doing this since 1987. I've been a researcher, as Kenneth mentioned, on actually now it's over 70 studies, and Actually, now I'm Kenneth. I'm the chair of the treatments committee, but that doesn't matter. Not vice chair, but that must have been an old CV. But I'll have to update that. But anyway, so when we know what we're treating, we can pick drugs more effectively. I summarized these on behalf of the American Epilepsy Society here in July, and of course 1 month later the FDA approved another drug. So now all of my hard work with my colleagues Barry Goodall from University of Wisconsin and Mindel Weingarten from Baylor, we put a ton of hard work into this, and then it's already outdated in 1 month, so there you go. But you can actually download this if you're interested. The best way to do it is to go to aesnet.org, and it's on our website, and this is really the story of the anti-epileptic drugs, except for Diacomet, which got approved in August. So you're welcome to go there. Free access, open access. That was just done as a public service by us. For doctors primarily. So you'll see it's really technical, but you might want to do it. Look it up. You may not understand everything, but you'll understand hopefully a little bit of the science behind what we do. These are things that you can do that are non-medicinal. Ketogenic diet, modified Atkins diet. By the way, ketogenic diet, I know even my daughters, just makes my head spin. They're like, oh, I went on the internet and I'm doing the keto diet. And I'm like, do you know that can cause kidney stones and metabolic problems, and you have to be hospitalized and you have to be followed by a doctor? And oh, no, I'm doing it on my own. Anyway, you really should be supervised by a dietitian and some kind of either nurse practitioner, doctor, or something like that. The ketogenic diet does have significant complications. A modified Atkins diet is something you can do at home. It works about as well, and it's a lot easier. Ketogenic diet is super strict. Anybody done the ketogenic diet? Yeah, a few. Okay, yeah. I haven't done it, but we can talk about your experiences later if you want. Vagus nerve stimulator, now 21 years old, no more effective than an anti-epileptic drug. Likewise, responsive neurostimulation, no more effective than an anti-epileptic drug. Deep brain stimulation for selected patients, that'll be kind of interesting. And then surgeries, again, Dr. Gwynn's here to talk about that. So cannabis as an alternative therapy. Well, is it really an alternative therapy? Is it a non-medicinal therapy? It's plant-based, yeah, but it's a drug. It is a drug, and if you don't think it's a drug, you might as well, tune me out now, because it is a drug. Yeah, I know everybody hears the good stories, right? But you don't hear the bad ones. I do. I hear people coming in and say, I used that stuff from my local dispensary, and God, it made my seizures worse. Or I couldn't sleep, or I was having hallucinations, or I couldn't think. Others say, yeah, it really helps me. So there's good and there's bad stories. There are animal studies that have suggested that this is a class, by the way, a class. When you get cannabis, there's about up to 500 different active ingredients in cannabis plant, and there's different plants, there's different strains, indica, et cetera. I know that, I understand all that, but there isn't like a strain that is 100% pure CBD, which is the one that's thought to work. So. Then there's animal studies that have suggested they might work, and those were older studies that were reviewed by Oren Davinsky and his colleague in New England Journal of Medicine 3 years ago. But more importantly, based on pressures from patient groups to study this, and a number of people, especially led really through leadership by Oren Davinsky at NYU, completed these studies, and we do have the results now of 2 studies. So again, what's in cannabis? Cannabis is a plant, as you know, and it has depending on different people's estimates, 60 to 500 different cannabinoids. These are chemicals that are in the cannabis plant, and most of them are active pharmacologically. They do something to you. So you're not like tobacco has, I guess if you think about it, tobacco has nicotine in it, yeah, but it also has a lot of other carcinogens, things that cause cancer in it. So it's a plant-based drugs, unless they're absolutely purified, are going to contain a mixture of substances. Despite what most of the labels say, oh, this one has, 20% cannabidiol and 1% tetrahydrocannabinol, which is, by the way, what gets you high, the labels have been found to be inaccurate and incorrect. So just because it says it on the label at your local dispensary doesn't mean it's true. The brain has cannabinoid receptors, which bind substances in our body that are in our brain that are called endocannabinoids. Endo means inside. So these are substances that our brain makes, and there are receptors on other nerve cells, neurons, that these substances bind to. Now, these endocannabinoids are not in our brain and coincidentally binding to cannabinoid receptors. That's the purpose of the cannabinoid receptors. Human beings experimenting around with various kinds of plants found that these drugs would get you, the plant would get you high, and the reason is because we have the receptors, the receptors aren't there for marijuana. Marijuana works because the receptors are there. Does that make sense? Interestingly, CBD doesn't bind the cannabidiol receptors, so its mechanism of action is still being researched. The research into this, as you know, was held up for decades because the Drug Enforcement Administration, which is a division of the U.S. Justice Department, headed, as you know, by former Senator Jeff Sessions. So Jeff Sessions is in the news a lot for lots of things, and he heads the DOJ, and the DOJ is over the DEA, and the DEA controls how restricted drugs are. And currently, if you probably know this, but if you don't, it's still a Schedule I illegal substance in the United States of America at the federal level. The majority of states now, more than half of the states, have legalized marijuana in one form or another, either for medicinal purposes or recreational or both. We have it for both in this state. I'm sure everybody in the audience is aware of that, but we're in conflict with federal law. So don't cross state lines with even medical marijuana that you buy at a dispensary. I'm not quite sure how that's going to work out for Epidiolex. I think it'll be okay, but don't quote me. I'm just thinking, and I'll tell you why in a minute. So if you have drugs, cannabinoids, that will bind these CB receptors, depending on the percentage of THC, you might get these sort of euphoric or even psychotic feelings. We know that THC does affect memory, cognition, movements. There have been studies here in children that are using marijuana, that kids in school, that they actually, when they're using, they're not thinking as clearly, they're not learning as well. When they stop using briefly, even for a couple of weeks, their memory, their thinking improves. So that's a whole other issue that has nothing to do with my talk, but just to be aware of it. It is used, these compounds are used in treating pain, nausea, as you know, spasticity, for example, in MS. And there's good data that show that, and there's a couple of drugs like Marinol and others that are approved for nausea. Those are synthetic cannabinoids that have been used for years for treating nausea in cancer patients and HIV patients. It can affect your sleep. It affects neurochemicals, acetylcholine, dopamine, glutamate. So it's not just effects on these endocannabinoid receptors, but other effects are on our other neurochemical. There are other effects on our other neurochemicals, and even indirectly on opiate receptors in our brain, serotonin, which regulates sleep, GABA, which is an inhibitory neurochemical in our brain, and NMDA glutamate, which is an excitatory neurochemical in our brain. But again, CBD doesn't bind these main receptors, so research is continuing into this. Well, what do we know about animal research? Well, it may be that there is some effect on glutamate receptors. There were 2 early studies that showed that cannabinoids might have anti-seizure effects in animals, but one of them showed in rabbits that low-dose THC caused seizures. So we have to have some healthy, honest, take a healthy, honest look at this. And 2 different studies showed that THC, tetrahydrocannabinol, can be proconvulsant, can cause seizures in rodents who are bred to have epilepsy. So there were some early clinical trials that had some mixed results. One study with 4 patients, I'm not sure what that tells you, showed that 2 of the patients became seizure-free. Well, the number is so small that you really can't make much out of that. One study looked at 8 patients with convulsive seizures, tonic-clonic seizures, and 7 got placebo. And in that one, interestingly enough, there seemed to be some signal that CBD did do something. 7 out of 8 of those who got CBD were benefited, as opposed to 1 out of 8 who got the sugar pills. But in another study where they gave 200 milligrams of cannabidiol to 12 patients in institution, they didn't find benefits. So there's been other studies, not really scientific studies, but surveys of parents on Facebook. We all know how reliable Facebook is. And, it could have been Russian hackers, I don't know. So trolls in St. Petersburg, who knows, right? So we've got to be careful about that. One looked at hospitalizations, and 2 studies looked at groups of patients' self-reports. And I think, there was enough sort of smoke there that there was a lot of interest in doing some clinical trials. And Oren Davinsky's group at NYU looked into this and published this a couple of years ago in Lancet Neurology, which is a respectable journal. This was an uncontrolled study, open label, so everybody was getting cannabidiol, and we're just like, say, oh, how did that work for you? And so they did find that the seizures were reduced by about 1/3, which is kind of modest, but these are probably also people who have pretty hard to control epilepsy. They've tried many drugs, maybe surgeries, and they're kind of going for this because it's like, well, what do we got to lose? Let's try this. Those patients are more likely to not respond. So that's kind of a little encouraging. But I guess I would draw your attention to this. 79% of them said they had some side effects during the study. Again, it's open label. It's they know they're getting the drug. Well, we don't have a placebo group. How does that compare? We don't know. How about serious side effects? 30%. So again, guys, keep this in mind, side effects. So in 2014, the American Academy of Neurology did a huge study of cannabis for all kinds of things: headache, pain, spasticity, multiple sclerosis, epilepsy. Let's just focus on epilepsy. What did they find? There were no good high class refers to the level of scientific evidence, how well the studies were done. There were no class 1, 2, or 3 randomized controlled trials. Randomized controlled trials are what we need if we're going to draw conclusions. These sort of story reports, class 4, are just stories. And so they concluded at that point, as did a group in England, the Cochrane Library, a very respected group that looks at what's the evidence, how solid is the evidence. They couldn't draw conclusions. This was only 4 years ago. Well, when you're looking at any drug, when we do pharmacology studies, when we do device studies, surgical studies, we have to look at, is what we're doing effective? We have to compare it against blinded placebo patients. Now, it's hard to do with devices and surgeries, but for drugs, it's easy. You give them a sugar pill, you give them the real stuff. Nobody knows. I don't know. They don't know. The people who are recording seizures don't know. We're all blinded. We're just reporting what we're seeing. Okay, so that's how we do these studies. Is the drug effective? We also can determine by doing these blinded studies, is the drug well tolerated? Are there immediate side effects? Are there long-term side effects? And what about safety? Are there other things in there? Things like, what are the long-term side effects? Does it affect a child's development? Are they going to not learn as much and not be as smart if they take this drug? Of course, you have to think about, well, if they keep having seizures, that could have bad effects on learning and memory, of course, in children. That's what we're very concerned about. What about things like quality control? The FDA doesn't supervise the stuff down at your local evergreen marijuana store. There's no supervision. Do you know that the state of Washington puts a sticker? Do you ever look at a gasoline pump? There's a little sticker there, and it has little punch marks on it, and it certifies that when that Chevron station says they delivered 1.0 gallons of gas, that you really got 1.0 gallons of gas. When you go to the produce counter in your local Albertsons or Safeways, and you put your apples in the thing that weighs them, the hanging scale, there's a little scale thing that says this scale's valid. It's been certified. It's been checked by an independent agency. Is anybody doing that for the drugs you're putting in your body from a dispensary? No. So how do you feel about that? Think about that. Are there pesticides in there? Where's it coming from? Is this from Mexico? Is this, are there adulterants in there? Are there fungi, viruses, animal feces? Probably. So, seriously, think about it for a second. So when we do these studies, we have to randomize placebo versus control. Typically, epilepsy studies have 8 weeks where you're on your medication, and then you continue your medicine. Half the people, we don't know who, gets marijuana, well, CBD in this case, half get placebo, and that's a randomized controlled trial. We have to record all of the side effects, everything the patient says. Even if a dog bit them on the street corner, when they're out waiting for a metro bus, that's still a side effect, okay, that occurred during our clinical trial. May not be related, but, my brother knocked me over and broke a tooth. Well, we have to report all that stuff. And if it occurs in a clinical trial, we have to report it, no matter what. We sort it out later. Also, what are the long-term and serious side effects? Very important. So, 2 big studies have been done and published so far. By the company GW Pharmaceuticals of England. That's the same as Greenwich Pharmaceuticals in the United States. The reason it's called Greenwich here is because there's another GW, I don't know, whatever company here in the United States, and the FDA said, well, you can't have the same name, so change it. And so they thought, well, Greenwich, it's Greenwich, England. That's where the atomic clock is. It's in England. We'll just change GW to Greenwich. So if you hear Greenwich, that's the name in the United States. GW is the English company. That's the parent company. They decided to extract pure CBD from plants. They eliminated everything else, all the THC. These are grown in botanical gardens. There's no pesticides. There's nothing. You know where it's coming from. It's 100% pharmaceutical grade, regulated, and the lab and the production of this is supervised by the FDA. The FDA even goes, by the way, to international pharmaceutical manufacturers in India, Bosnia, Israel, whatever. They actually do site visits, and they look at manufacturing practices. I actually, one time many years ago, got to visit a pharmaceutical manufacturer and actually see pills being made. It was actually quite interesting, and I was impressed by actually the regulation. They have to maintain logs, and the FDA will come in there and they'll say, let me see, I need to see all your logs. And they do this. Puerto Rico, before the bad storm, we used to do a lot of offshore drug manufacturing. The big pharmaceutical companies in the United States used to do that in Puerto Rico, and regularly there were problems with one of the anti-epileptic drugs because it was a very hard drug to manufacture, and commonly that Puerto Rican manufacturing company would get closed down by the FDA, and we'd get a big shortage of this particular drug. Anyway, the point is that these are highly regulated. So they looked at this very rare condition called Dravet syndrome. They looked at Lennox-Gastaut syndrome. Let me just see, I think. Yeah, so in Dravet syndrome, again, what the main thing, the primary thing they were looking at was what is the percent reduction of tonic-clonic seizures in these children in placebo versus CBD. And so going into it, in the placebo group, it turned out they were having on average 12 tonic-clonic seizures per month. That's almost every other day. And that was the CBD group. So even a little higher. It was almost 15 in the 15 tonic-clonic seizures per month in the placebo group. And what you can see is when you give placebo to these children, they don't know they're getting it. The parents don't know they're getting it. They don't know which you're getting. The placebo had no effect. It didn't work. Well, it's a sugar pill. You'd expect it not to have an effect. But if you look at the effect of the CBD at 20 milligrams per kilogram of body weight, we always do it kilograms, so you have to take your weight in pounds, divide it by 2.2, that's your kilogram weight. And your average adult male supposedly is 70 kilograms, just for reference, woman is 60. But this is weight-based for children, so you give 20 milligrams per every kilogram that the person weighed. Look at the effect. I mean, cut it in half. So that was very statistically significant. And if you look at it another way, which is how the European Medicines Agency wants it looked at, which is what's called the responder rate, what percentage of people have their seizures cut by at least half? Maybe that's a more meaningful result. I don't know. FDA wants it this way. EMA wants it that way. Used to be the other way around. But anyway, EMA and FDA flipped about 10 years ago in what they want. But it turns out it's always about the same, interestingly enough. 43% reduction. 43% of people who got CBD in the Dravet study responded. They had at least a 50% reduction, and only 27% placebo. For Lennox-Gastaut, which is a more common condition, although I ran my numbers, and out of the thousands of patients I have, I only have 30 patients, but they are very hard to control. They have a lot of patient visits, emergency room visits. Just had one in the hospital last week. They have very bad seizures, hard to control, as I mentioned. What about these? And looking at children and adults now, the median reduction or the percentage reduction here, this is reporting the data a little bit differently, but they got a 50% reduction with the full dose compared to 21% with placebo. And looking at it the way the Europeans want it, 44% with the drug and 24%. So the FDA said, yeah, these are reliable. We agree that this is a effective drug for these two syndromes. Let me back up in terms of, let me go forward here in terms of side effects. So guys, this is the real deal. There's no free lunch. That's an unfortunate reality of us, of humans. we wish everything was all roses and it's effective, but it doesn't have any problems. Well, it does have problems. Okay, it has Epidiolex brand cannabidiol, that's what Greenwich produces. That's their brand name. This is what it looks like. It's a liquid. It comes in a bottle. It has to be drawn up with a little syringe, not a needle on the end, but a blunt, just an open syringe. And you just put it in the mouth and have to swallow it. It caused, much greater than in the placebo patients, the following side effects: diarrhea, sedation, fatigue, fever, vomiting, decreased appetite. Interesting. We all know, you smoke weed, you get the munchies. Well, it doesn't happen with CBD for most people. Also elevates your liver enzymes. So it's doing something to your liver. Your enzymes that are leaking into the blood all the time, there's a certain range, usually between 40 micrograms per ml, or millimolar, sorry, for the technicians here. But they'll be up in the 60s, 70s, 80s. Is that a problem? Remains to be seen, but we have to be aware. Doctors kind of get a little nervous when we go, ooh, the liver's a little, what is this, inflamed, irritated? What does this mean? I'm not quite sure myself, so stay tuned on that. Also, the kids, both in the Dravet and the Lennox-Gastaut studies, the ones that were on CBD, the parents elected to quit the studies more often than those that were on placebo. So when patients quit studies, there's usually reasons for that. And we'll have to kind of figure that we're still in discovery. Now that it's going to be marketed, we're all going to have to learn about this together. The other thing, too, is real drugs cause drug interactions. They interact with other drugs. Well, I would submit that cannabidiol is a real drug because it not only works, but it has side effects and has drug interactions. Sounds like any other drug I know. It affects topiramate levels, rufinamide levels, clobazam levels, zonisamide levels, and acylcarbazepine levels. So I'm not trying to sound negative. I'm sure I do. That's not intentional. I just want you guys to be really kind of careful and just not like jump in with both feet, not knowing how deep the water is or even what kind of water you're jumping into. Is it polluted water? Is it salt water when you think it's crystal clear fresh water? You just have to be open eyes about this stuff. So here's, I'm going to finish rewriting this position statement for the American Epilepsy Society this weekend with my colleagues, and we're submitting it to the board on Monday. Basically, we're saying the following. This is our new position statement. We had an old one from 2014. It's out of date. Obviously, with the new data, we need to update it. And so here's what we're saying. Pure laboratory-grown, research-grade CBD, cannabidiol, helps some people, but it has side effects and drug interactions. That's a fact. You can argue with me? Fine. That's a fact. Artisanal brand, artisanal cannabis from a local marijuana shop has been shown to contain unknown quantities of THC and CBD, although the labels are not trustworthy, so you really can't totally count on that. And it might contain pesticides, herbicides, fungi, bacteria, animal feces, whatever, hair. So just use caution. There's an old, I'm a Latin scholar, there's an old saying, caveat emptor. That means let the buyer beware, and you need to beware. So a month ago, I was in Amsterdam Netherlands, and of course everybody knows Amsterdam has been a pretty shall we say a liberal city for many years on a few counts. One of the things they of course have is open use of marijuana, and boy, I can tell you they openly use it. You just have to walk down the street and you're like, whoa, okay. So this is just one random out of probably hundreds of storefronts in Amsterdam that I took a picture of. And so as some of you know who may be marijuana aficionados, and I have them in my practice, so I know they exist. There's all these different strains and stuff, and then they're touting their own CBD here. So I don't know if it's regulated in the Netherlands, but I can tell you it sure isn't regulated here. Let's see. So does it contain what it says on the label in the local shop? Who knows? The Seattle Times did an independent investigation. They went to 6 different, I'll call them pot shops in the Seattle area, Puget Sound area, and they took samples. They looked at the labels that said, okay, this has 5% THC, 12% CBD, and other stuff and whatever. And they took samples from 6 different vendors, wrote all this stuff down, and they actually sent each sample from the 6 different shops to 6 different laboratories. So here's the real problem. Not only did the laboratories not agree with the percentages that was claimed by the pot shops, but the laboratories couldn't even 100% agree. There was some I guess these things are hard to assay. You can't exactly quantify it accurately. So we just don't really know. There could be other things, as I mentioned, and there's no regulatory agency. Also, how much do you take? If you can't trust the label, patients say, well, I just do like a dropper full and a half. And I'm like, well, how many milligrams is in there? Wow, milligrams? What? Wait a minute. We got to do milligram per kilo, guys. So will it cause you side effects? Is it going to have drug interactions? Is it going to make you sick? So the bottom line is this. I'll finish here and leave you maybe a few minutes for questions. We have these new seizure names and epilepsy terms. I wanted to just introduce them to get them out there. 29 anti-epileptic drugs are approved. Epidiolex is here. Be wary of artisanal cannabis. I'm excited it's here. And my colleagues at Valley Epilepsy Center are aware of all this stuff and here to help out as well. So with that, I'm going to just kind of stop and let you ask a couple of questions. Surely there cannot be silence after this. I think surgery is going to be far less controversial, but yes, ma'am.
I'm just confused by your talk and the fact that Children's is prescribing this.
What is Children's prescribing?
Well, I just have students in my school that are being prescribed or they're doing trials and such. So
Children's was involved in the trials here of Epidiolex. Mm-hmm. And Epidiolex was approved by it's on the market. Their table's right outside. It was approved by the FDA June 25th. It was approved by the Drug Enforcement Administration and given Schedule 5, which is low schedule, by the way, which is good, so we can prescribe it. That was on September 28th. And the Washington State Pharmacy Commission just met a week ago Monday on the 22nd, and unanimously recommended to the full pharmacy board in the state that we make it available. So it should be available here commercially. But if you're a teacher and you have students that are getting it, unless they're in a trial, they're just getting it from the local pot shop.
So are you prescribing it to any of your patients?
It's not available for prescription yet.
Okay.
We don't prescribe stuff you get from the pot shops. You do that on your own.
So the patients here on a trial.
They're in a research study.
Okay.
I don't know. I don't know your students, but.
Mm-hmm.
So then is it still commercially only going to, when it's commercially prescribed, is it only going to be for those 2 syndromes, or is it for other syndromes as well?
Yes, it's not approved for anything else. Now, if we prescribe, we can legally, once it's available for prescription, it's approved by the FDA, DEA, and the Washington State Pharmacy Commission. Any physician can prescribe we could prescribe a blood pressure medicine for your seizures, even if it's not, we could prescribe it. Now, is that right? That's one thing. Number 2 is the insurance company going to pay for it? And that's really the thing I think that we're going to be facing with Epidiolex. Most of my patients have something other than Lennox-Gastaut, and I only have one Dravet syndrome patient. So for the 99.8% of my patients who have everything else, I could prescribe Epidiolex for them. I'm allowed to do that. That's perfectly kosher. That doesn't mean Regents or Premera or Medicare or state Medicaid is going to pay for it. They oftentimes won't. They will have pharmacy benefit managers, they're called PBMs, that'll come in, they'll look at the records and say, well, Vossler, your patient doesn't have Lennox-Gastaut syndrome, they have temporal lobe epilepsy. We're not paying for it. I could prescribe it, you can take it, but you'd have to pay cash.
Okay, last question. Dr. Vossler, are you going to be around after this, or are you
For
going to take off?
Just a little while, yeah.
Okay.
I've got to
So
go
he
back.
might be
I
able
have
to
to go
take some
back to the
questions.
hospital, I'm sorry. I had to stop at the hospital and discharge a patient back to Alaska this morning, and I got to go back. But anyway, I will stick around because I know it's a hot topic. Yeah.
Hi, are you aware of any movement to better regulate or actually just regulate the quality of these drugs? Because you've talked about the effectiveness, but
Right.
what was eye-opening to me was the fact that they could have all of these other things in them.
They could.
And that, I could see two avenues of regulation. One would be self-regulation by the manufacturers.
We'd love to
Are
see
you
that.
hearing anything about them saying, hey, we want to set standards, we want to be on the forefront of this? And also, are you seeing anything with the state government or the feds in terms of saying, we are going to set standards and we're going to
Yeah.
hold people accountable?
Yeah, great questions and good suggestions. I think self-regulation would be the first step, and we can talk about how that's worked in other areas in like the regular pharmaceutical industry with the pharma group. They kind of came in and said, look, if we don't do it to ourselves, the feds are going to do it to us. So let's form this pharma group and let's agree on how we market drugs. And that, I think, was a good thing. I haven't seen anything like that right now yet, but we need that. Right now, there is a bill before Congress called the Farm Bill, and it is up for a vote Monday in Congress. The Farm Bill it's a big bill that Congress, I don't know it's all kinds of stuff in it, but there's a little provision about allowing farmers to grow hemp. Farmers can grow hemp. Hemp is, part of the fibrous part of marijuana, cannabis plants that makes rope and other things like that. But this farm bill that's before Congress, which is going to be voted on, it goes beyond that. It says, will these farmers who are growing hemp also be allowed to extract cannabinoids from the hemp? And so we had a big discussion at the American Epilepsy Society Executive Committee this week. Like, are we going to wade into this? And we decided that it's not really within our purview to be telling farmers or states, that they need to be regulating this. I think, we want to make sure what people are taking is safe. And so I think, I don't really have a good answer yet, but this is evolving. It's an interesting time, I'll just say that. It's evolving, and it needs to evolve. Okay, I think we're out of time, huh, Kevin? Okay, thank you.